All right, we are here talking about critical care pharmacology. So these are a lot of the medications that we use in the cath lab, and we're just going to go through them. So our objectives are to increase patient safety by improving cath lab staff knowledge on use of critical care pharmacology, promote staff initiation of applicable critical care medications, and increase understanding of dosages, indications, and side effects of critical care medications. So why do we need to learn this? We have higher acuity patients. We have an increased volume of patients to provide safe, quality patient care. There are high-risk situations that require quick and confident decisions. Being knowledgeable about medication indications and dosages warrant a questioning attitude, and to identify which medication is best suited for each situation. So we've got our adrenergic agonists. Those affect the alpha-1, alpha-2, beta-1, and beta-2 receptors. They're catecholamines, so they have short half-lives and cannot be administered orally due to breakdown in the liver. And they do not cross the blood-brain barrier. And then there's non-catecholamines. So your alpha-1 receptors affect your arterioles, coronary, visceral, cutaneous, veins, internal sphincters, and iris dilator muscle. Your alpha-2 receptors affect your presynaptic membrane, pancreas, veins, adipose tissue, GI sphincters, and salivary glands. Your beta-1 receptors affect your heart, your SA node, your atrial muscle, AV node, ventricles, kidneys, and adipose tissue. And your beta-2s affect your arterioles, muscular, veins, bronchi, liver, pancreas, uterus, and iris constrictor muscle. So your alpha-1 receptors are going to cause vasoconstriction and mydriasis. They promote hemostasis, nasal decongestion, local anesthesia, increased blood pressure, and the adverse effects are all based on vasoconstriction, so hypertension, necrosis, bradycardia. Alpha-2 receptors inhibit the release of norepinephrine. They reduce that sympathetic outflow to the heart and blood vessels. There's a relief of severe pain, and there's no relevant adverse effects. Your beta-1 receptors are positive inotropes. They promote contractility. They improve cardiac performance, treat heart failure, shock, AV block, cardiac arrest, and then the adverse effects are tachycardia, dysrhythmias, and angina. Your beta-2 receptors act on the lungs in the uterus. There's treatment for asthma and bronchodilation, delays preterm labor, and adverse effects are hyperglycemia in diabetic patients and tremors. Your dopamine receptors will dilate the renal vasculature for treatment of shock. Dopamine is the only drug that can activate these receptors, and it enhances cardiac performance by activating the beta-1 receptors. So here's a little picture I drew for you guys, showing kind of where all of those receptors affect. So your dopamine receptors promote that renal blood flow to prevent that renal failure. Alpha-1 receptors increase peripheral vasoconstriction, so those are the green ones, kind of all those distal vessels. Alpha-2 receptors are in the CNS and reduce sympathetic outflow to heart and vessels, decreasing sympathetic effects. Your beta-1 receptors increase heart rate and contractility in the heart. Your beta-2 receptors promote bronchodilation. So I always remembered the beta receptors as beta-1, you have one heart, and beta-2, you have two lungs. So there's multi-receptor activation. Anaphylaxis is the main one, which is a severe allergy. It causes hypotension from massive vasodilation, bronchoconstriction, edema in the glottis, and your treatment is epinephrine. So that activates alpha-1, alpha-2, beta-1, and beta-2. It increases cardiac output and blood pressure through vasoconstriction, and vasoconstriction decreases that glottal edema. Epinephrine activates alpha-1, alpha-2, beta-1, and beta-2 receptors. It's a catecholamine. Vasoconstriction will delay the absorption of local anesthetics, control superficial bleeding, and elevate blood pressure. The increased heart rate will overcome AV block, restore cardiac function and cardiac arrest, and bronchodilation. So epinephrine activates all of these receptors. Those alpha-1 receptors increasing that peripheral vasoconstriction. The alpha-2 receptors reduce that CNS outflow to heart and vessels, decreasing that sympathetic effects. Your beta-1 receptors will increase your heart rate and contractility to the heart, and beta-2 receptors promote bronchodilation. And if you think about that, that's what we want in treating anaphylaxis as well as in a code situation when we're giving epi. We want that increased blood pressure, we want that increased heart rate, and we want those lungs to open up. The adverse effects are hypertensive crisis, dysrhythmias, angina pectoris, necrosis following extravasation, hyperglycemia in diabetics, and then administration is IV, IM, sub-Q, intraspinal, inhalation, and topical. Primarily, we're going to be giving it IV. Sometimes we give sub-Q. Neosynephrine. This is not one that we're usually giving, but it's good to know about. It's an alpha-1 receptor activator, so it increases peripheral vasoconstriction. It has the minimal effect on beta receptors and often has profound bradycardia associated with increasing use for cessation of some tachyarrhythmias. It's used for treatment and shock and is found in cold medicine for nasal decongestive properties. All right, so then we have norepinephrine, which activates your alpha-1, alpha-2, and beta-1 receptors. So it's a catecholamine, promotes vasoconstriction, which delays the absorption of local anesthetics, controls superficial bleeding, elevates blood pressure, increases heart rate to overcome that AV heart block, and restores cardiac function in cardiac arrest. We can see that it affects the alpha-1, alpha-2, and beta-1, and kind of does a lot of those similar things as epinephrine does, but not as much on the heart rate. So the adverse effects of norepinephrine are hypertensive crisis, dysrhythmias, angina pectoris, necrosis following extravasation, and then the clinical application is only in hypotensive states and cardiac arrest. Used by continuous IV only due to a short half-life. Dopamine will activate your dopamine receptors, and it is the only drug that will, as well as beta-1 receptors at moderate doses and alpha-1 receptors at high doses. It's a catecholamine and is dose-dependent receptor specificity. It's indicated in shock for increasing cardiac output with beta-1 receptors while increasing renal perfusion to prevent renal failure. High doses do decrease renal blood flow due to the alpha-1 receptors' responsive vasoconstriction, and can also be used in heart failure to increase myocardial contractility and cardiac output with activation of beta-1 receptors. So at low doses, the dopamine receptors promote the renal blood flow to prevent renal failure. Moderate doses, beta-1 receptors increase heart rate and contractility. And high doses, the alpha-1 receptors kind of take over and increase peripheral vasoconstriction, which in turn decreases that renal perfusion. Dopamine adverse effects are tachycardia, dysrhythmias, anginal pain, extravasation, necrosis. And your initial doses are 2 to 5 mics per kilo per minute, increased to a maximum of 50 mics per kilo per minute as a continuous IV infusion. Dobutamine will activate beta-1 receptors only. It's a catecholamine and indicated for heart failure. The adverse effect we see is tachycardia, and it is a continuous administration, 1, 2, or 4 milligrams per ml in 250 ml doses, and then 2.5 mics per kilo per minute, all the way up to 10. So we can see dobutamine will activate just that beta-1 receptor, increase heart rate and contractility in the heart, and it is the only receptor that activates just the beta-1. Adrenergic agonists. Be confident in emergency drugs to prevent medication error. All adrenergic agonists and antagonists are considered high alert medications, which can lead to devastating effects if errors occur. So please keep your patient safe and double check your teammates for safety. So then we're moving on to adenosine. So adenosine is a systemic antiarrhythmic with SVT termination. It will slow conduction in the SA node and dilate coronary vasculature. It'll depress the LV function, and it has a short half-life, which allows use in patients with poor LV function. It's used in FFR, as it dilates the vasculature. The stenotic area can be tested to decide on the treatment plan. Atropine is an anticholinergic drug. It blocks the action of acetylcholine, increases heart rate, and decreases secretions. Used in vagal responses, and the vagal response is caused by a parasympathetic nervous system activation. It causes decreased output and requiring heart rate or stroke volume, hence atropine. Amiodarone is an antiarrhythmic for ventricular and supraventricular arrhythmias. It's life-threatening arrhythmia management and given during cardiac arrest. The first dose is 300 milligrams and the second is 150 milligrams. Your IV drip rate is going to be a bolus of 150 milligrams over 10 minutes IV, and then 1 milligram per minute for 6 hours, and then 0.5 milligrams per minute for 18 hours. Cardizem is a calcium channel blocker used for arrhythmias, hypertension, SVT, and vasodilates the coronary arteries. Nipride is used for hypertension, must be continuously monitoring blood pressure while administering. It relaxes the smooth muscle, venodilation, reducing preload and systemic vascular resistance, and coronary artery dilation. It's used in right heart caths to address vasoreactivity. Labetalol is an alpha-1 and beta-1 receptor blocker. It's used for hypertension and tachycardia, causes vasodilation, and decreases contractility and heart rate. Sodium bicarbonate is an alkalizer, used for metabolic acidosis, 50 MEQs for cardiac arrest, and hyperkalemia. It's offered in a one-time use syringe in the crash cart. So anytime our pH is low, we want to be considering sodium bicarb. Precedex is a sedative in conjunction with moderate sedation. It aids in decreasing the necessary dose of opioids and barbiturates for sedation. Special consideration are used with caution in patients with conscious sedation as it prolongs the half-life of drugs like Versed and fentanyl. Propofol is an anesthetic induction and maintenance. If we're using this, the patient must be intubated. Physician must be present to give the order. Respiratory and cardiovascular depression are often side effects, and the dosing is 1 milligram per kilo, and it's off-label use in procedural setting. Protamine is used rarely for the treatment of heparin overdose, but it's used commonly in the IVS for the reversal of heparin for groin closure, post-op structural heart procedures, as well as a lot of our EP procedures. It's also used to prolong the effects of insulin, and special considerations are to administer it slowly to avoid bradycardia and hypotension. Not everybody has this response, but some patients here and there do have a reaction to that protamine. NPH insulin also contains protamine, and so be aware if the patient is on NPH to possibly decrease that dose. Adverse effects are anaphylaxis, nausea, vomiting, dyspnea, bradycardia, hypotension, flushing, warmth, and then severe hypotension can occur with rapid IV administration of protamine. Angiomax is a direct thrombin inhibitor, antifibrin, and used intraprocedurally. It's weight and creatinine clearance based, and the treatment and prevention of arterial thrombosis. It will lower the incidence of systemic bleeding, and it's more precise in anticoagulation than heparin. ACTs are used to determine the efficacy, but the value remains high long after Angiomax has been stopped. Whereas heparin, as you give more heparin, your ACT goes up, and you wait for it to come down. The ACT is not as relevant to the Angiomax just to determine that it is actually working. So heparin is our anticoagulation therapy as well. It's a thrombin inhibitor. The anticoagulation status directly correlates to the ACT value, as we just mentioned. It's used in PTCA procedures for anticoagulation and is used exclusively in CTOs. It inhibits factor 9 and factor 10 and prevents further thrombus formation. Argatroban is a selective thrombin inhibitor. It's highly selective. Used in thrombus in patients with HIT and works against free and clot-bound thrombin. It's commonly used for infusion precath for NSTEMI patients with a heparin allergy. Integralin is indicated in conjunction with heparin and aspirin for the treatment of acute coronary syndrome, particularly in patients who are undergoing percutaneous coronary intervention. Considerations are that unfractioned heparin should also be administered and continue eptifibatide infusion until discharge or up to 18 to 24 hours, whichever comes first. A minimum of 12 hours infusion is recommended. TPA enhances the conversion of plasminogen to plasmin by binding fibrin, initiating fibrinolysis, and with limited systemic proteolysis. It's used in the cath lab for directed administration to PE and DVTs, and the most common complication observed with thrombolytic therapy is hemorrhage. Cangrelor is used to reduce the rate of thrombotic cardiovascular events in patients with unstable angina, NSTEMI, or ST elevation. Once therapy is complete, it should be followed by an oral P2Y12 platelet inhibitor agent like Plavix or Brilinta. Special considerations, reconstituted Cangrelor will be clear, colorless, or pale to a yellow solution. Diluted Cangrelor is stable at room temperature and up to 12 hours in D5 and 24 hours in normal saline. After 2 hours of the infusion, the drip should be changed to a 0.75 mics per kilo per minute at the physician's discretion. Etomidate is an intubation medication given for induction of general anesthesia and given IV push. Should be given by or under anesthesia supervision. The rapid sequence intubation, 40 milligrams in a 20 ml vial. The dose is 0.3 milligrams per kilo IV push. And succinylcholine as well is another intubation medication. It's a muscle relaxant. Should be given by or under the anesthesia supervision. The rapid sequence intubation as well, 200 milligrams per 10 mLs and 0.6 milligrams per kilo IV push. And so those should really only be given by the anesthesiologist or if they are actively intubating and need you to push it for them. But typically, they are the ones who are pushing it all by themselves. And that's all I got for you.